Thank you, Shripriya, and thank you everyone for joining us on time. As Shripriya was mentioning, today we have a very important session, very a session which needs very much interaction and inputs and views from all of you. And today we have as our faculty, Dr. Sanghamitra. Sanghamitra is a qualified family medicine doctor and has done her post-graduation in MSc in palliative medicine from Cardiff University, UK. And currently she is working as a lead palliative care and as Assam Cancer Care Foundation. And she is volunteering with Arjuvan, right, Sanghamitra? I always pronounce it wrong. Arjuvan Healthcare Foundation, and she's a faculty for the IAPC national course as well as the NHSRC. NHSRC is a National Health System Resource Center, which comes under Ministry of Health and Family Welfare. So welcome, Dr. Sanghamitra. And she's sitting back to back for the second session today evening with two different topics. So thank you for joining us today evening.
Thank you, Shridevi, for that kind introduction. And I'm really glad that you've chosen me to take this very important topic on medical ethics, which is an important, we need to know about our ethical system. We need to know about everything that circulates throughout our practice. So I hope I'll be able to deliver. Please excuse me because I've been having some little trouble with the net system, so I'd like to switch my video off. Yeah, so sharing my screen, just give me 1 minute, please. Yes, can you all please see this screen?
Yes, we can.
Okay. Okay. Right. So we'll be talking about ethics in palliative care. So we'll discuss about what are ethics. We'll know about the 4 cardinal principles and little bit about that hot topic called euthanasia. So everybody is welcome to put in your questions. So ethics by definition is, the moral code of behavior. And these are a set of principles in a moral account, which should function as an analytical framework that expresses the general values underlying the common morality. So we'll just take examples of how these things happen. But before that, all ethical principles that guide palliative care are those of medicine in general. And interestingly, as doctors, we have dual responsibility. Number 1, to preserve life, and number 2, to relieve suffering at the same time. And in palliative care, especially at the end of life, the relief of suffering is more important as preserving life becomes increasingly impossible because we are not gods and our patients are going to die at one point of time. So these are the 4 cardinal principles as applied in palliative care. So what does the patient want? And does the family of the patient understand the preferences of that patient? And that is what constitutes patient autonomy. Will it benefit the patient? That is beneficence. Will it harm the patient? Any of our actions, will it harm the patient? That is non-maleficence. And is it a fair utilization of resources, which is justice? So these are the 4 cardinal principles on which the pillars of ethics, on which we as professionals work. There's something called ethical dilemma, because whenever you want to follow one path, the other one actually comes as an intersection and you will need to decide on what to do next. And there itself, you are in a dilemma. So it's a conflict of moral principles, basically. And when it occurs when a person faces certain situations where adhering to one particular principle might result in the violation of the other. Let us take some examples. For example, take this patient. This patient is an elderly patient in extreme pain with a jaw tumor and a orocutaneous fistula, as you can see in the picture. So, but the patient doesn't have any kind of distant metastasis. What will you do if the patient is refusing to take the NG tube insertion? Can we have some responses in the chat box, or anybody would like to give an opinion on this?
We will do the nasogastric tube insertion, ma'am, because it's in the patient's interest
Yes.
and it's in the patient's best interest,
Right.
irrespective of the patient's autonomy.
Okay.
I mean,
So, do you think that restraining the patient and then going against the wish of the patient would do something good for the patient? Is it like that, or you'd like to add something else to this?
There is a comment in the chat.
Yeah.
Without patient's consent, we cannot do any invasive procedure.
Yes, that is one point.
Then we have to accept the patient's right.
Right.
Like,
Absolutely. Absolutely. So everything that has been discussed is right, actually. So there's a dilemma between doing good, like that doctor previously said, that yes, we need to benefit the patient. We want to do it. It's the best interest of the patient, putting an NG tube. And then the thing on the chat box which said that it's patient's choice. We need to give that autonomy to the patient to take that choice, of refusing it. So what happens actually? Let us just see what is involved in decision making for the patient. Number one, the right to have the dignity, privacy, and confidentiality. Number two, the right to have information. Number three, the right to make decisions. And last but not the least, on the part of the doctor, the treatment decisions has to come as an informed choice of the patient. Okay. So this is patient's autonomy. The patient does not want the NG tube to be inserted. So what do we do as professionals? We take an informed refusal. Number one, we need to understand what the patient understands by refusing to the NG tube. Why is he refusing it? Explore the reasons. And then try to counsel the patient. Call him. Sit with him for a session. Maybe or one or two sessions. Maybe, if you can get the help of a counselor to find out the reasons why he's refusing it. Perhaps he has certain very major reasons of refusing it. Okay. It is not always that the patient doesn't understand the repercussions of not having the NG tube and then refusing it. And then you take an informed refusal. You have done everything from your side. You have counseled him. You have checked his understanding. You have explored the reasons. And still then the patient says, I don't want to have it. You as a caregiver, as the primary physician, will have to support the patient, even if you do not agree with the decision. So this is autonomy of the patient. And whenever you are in such kind of a dilemma, I would actually suggest you to follow these things. Let us come to another very interesting example. This is a 20-year-old boy with an osteosarcoma of the lower end of the femur. As of now, he has a large tumor, as you can see, multiple lung metastasis, and he has severe anemia. He wants an amputation now, but the procedure, according to you, is very risky, considering his general condition and the anemia. So you explain the risks to him of going ahead with the amputation, but then he's adamant that he wants an amputation. So what do you do? Any inputs? Yes. Anybody would like to give some suggestion on how to go about this
Counsel the patient.
regarding?
Uh, Regarding first, his opinion about why does he want to undergo an amputation,
Yeah.
and secondly, why do we as physician want to defer the treatment?
Yes, absolutely. Anything else?
There is something in the chat. Counsel him and try to comfort him with pain and other symptoms, and go ahead with the after informed. Go forward after return informed consent, and take informed high risk consent. Can help ask help from his loved ones to convince him about the treatment.
Okay.
One more comment. We can try to explain to him that he will never get the anesthetic fitness for the surgery considering his condition. And there are much better options for him at this stage.
Okay. So this is an example of a dilemma between doing good and avoiding harm. So you want to do good to the patient, and at the same time, you want to not do the amputation because you want to avoid the harm of doing the amputation. So this is an ethical dilemma between these two things. So ask him, you think about what are his chances of cure. Maybe you can sit with the patient, as you've already said in the chat, and then here also Dr. Arpita, I think. So explain to him what are his chances of cure, and at this point of time, if the patient doesn't know about the consequences of having a lung metastasis at this point of time, that will actually open that particular lock to his thoughts. Do you think the survival will be likely? You will need to explain these things. And will the amputation actually going to improve on his conditions? So these three things are extremely important. Right. So there is another ethical dilemma. There's a 20-year-old boy with advanced cancer, who is under your care. Now the relatives have actually insisted that issues of diagnosis and prognosis should not be discussed with him. When you go to see him one day, he's alone and he asks you what is wrong with him. Now what will you tell him? Any responses?
He is an adult, and definitely if the patient wants to know, then according to his autonomy, we have to very clearly, simply, and in not very descriptive terms, we have to explain to him what is the diagnosis and prognosis.
Yes, Dr. Deepak, I completely agree with you. I completely agree with you. So, we will not deliberately mislead a person at the insistence of the patient's relatives. That is very important. And as you said, a 20-year-old person or a child, is also an adult. But in an Indian scenario, sometimes we may have to take the family's wishes into consideration also. And here we should have, multiple sessions with the patients to find out their fears and, concerns regarding why they don't want to disclose the diagnosis or the prognosis to their patient. A child will always be a child for a parent, and they will go to any extent. A parent will go to any extent to protect their child from any kind of harm. And it is same here. I mean, the patient's relatives are protective about him, and hence they don't want to disclose this hard truth. But if we can make them understand the importance of what the child generally wants, or how that is going to help that child to take that prognosis, I think will be in a better position to manage this kind of a dilemma. I completely agree with what you said.
Dr. Arpita raised her hand.
Yes,
Yes, ma'am.
yes, yes, Dr.
I completely agree with both what you've said and what Dr. The other colleague of mine had said. But not doing in one session, but hearing the parents out. What you said is very correct, ma'am. As parents, they will always be apprehensive of what, and but as clinicians, we also need to assess the ability of how the individual will perceive, because everybody, the parents will always have a guarding or trying to shield the children, their own children. But children maybe, but it is on us of how we assess them, because as individuals everybody has a different ability to process things.
Absolutely, absolutely, Dr. Arpita. And I think these things generally would naturally guide us to take the next step forward. That is why it is important that we discuss this, thoroughly with the parents and with the patient also. So that, having multiple sessions with the parents separately, then few sessions with the patient, and then perhaps one or two sessions with both of the parties together.
Both the parties, yes, ma'am. Yes, ma'am.
So that there are no curtains left behind to be cleared up. So those, this might, seem a little impossible in Indian scenarios, but then when you take the lead, I'm sure, because in my experience, and of course, Sridevi would agree with me, we have actually come across these kind of sessions. We need to do a lot of communication with both the patient and the caregivers. I think, yes, I will definitely take that from you, doctor. Thank you. So another example, and this is an important one. I feel a 50-year-old lady with carcinoma of the stomach has come to the hospital in a terminal state, probably due to internal bleeding. So her systolic BP is 50 millimeter of mercury, and she's very, very restless. Will you give her parenteral midazolam, which may hasten death? Yes.
No.
Dr. Dilnaz.
No,
Yeah.
are coming
Ma'am,
in the chat also.
hello.
Yeah.
Yeah, ma'am, I feel we can just start with making her more comfortable with IV fluids or transfusion, or just counseling relatives and patient both together. In an emergency, patient is going to be restless because BP is falling. With the same time, the heart rate will increase because the cardiac input and output both are going to get hampered because of her internal bleeding stage. But once she gets settled with BP, I think the restlessness will reduce once we start counseling and giving her a symptomatic treatment.
Okay. So have you had your sessions on terminal delirium?
No, not yet.
This is like 5th session. So they just had pain, not yet communication.
Okay. Okay. So you see, in this case, number one, the patient is a terminally ill, advanced cancer patient. Okay, advanced stomach cancer patient, and we must demarcate the definition of advanced and terminal illness here. So I'm sure in your subsequent sessions, you're going to learn more about this. So I'm just giving you a point here that you need to demarcate between advanced and terminal illness. And again, you will need to prognosticate the disease. So you'll have a session on prognostication also. So, as this patient is in terminal restlessness, to say. So when the patient you have diagnosed the patient to be in terminal restlessness, you have to bear things in mind that the gold standard of treatment of terminal restlessness is midazolam. They're going to learn it about this particular thing, and maybe you can come back to this particular example and then reflect on why we are going to use midazolam. Okay, so maybe you're talking about the systolic BP being 50, which is issue of hypotension. And let me tell you that it is a usual finding which may not be corrected by conventional methods that you just told us about IV fluids and other things. Nevertheless, we do use them and can see negligible effects on the condition of the patient. Because when once you are in practice, you see terminal patients, there is internal hemorrhage, the BP is falling, the patient becomes restless. The one thing that you must do as a physician first is to calm the patient down by giving midazolam. Okay, so here the question, as we have already actually tried to bring up, is that is it right to give some medications here, which is midazolam, to a terminally ill patient, which may inadvertently hastens the patient's death? Okay, so this is the ethical dilemma here. If we have to see the the good effect of the whole thing, we need to understand the principle of double effect here. So it says that a single act of having two possible foreseen effects, one good and one harmful, is not always morally prohibited if the harmful effect is not intended. Now, point here, the midazolam, which is now in question, to bring it into use to calm down the restlessness of this particular patient, it will perhaps inadvertently hasten the death of the patient. But our intention is not hastening the death of the patient. Our intention is to calm down the patient, to relieve her of the terminal restlessness, which is extremely difficult for the patient to handle, which is extremely difficult for the patient's relatives and the medical staff who is handling this patient. Okay. Any questions here in this particular point? Okay. Yes, please.
It was just that the way the question was worded, that was a little unsettling, because it said that we want to give midazolam to hasten the death and not to make the patient comfortable. So the priority would be to mention that we want to make the patient comfortable instead of like focusing on the hastening the death part. So that was the only thing that I wanted to ask, because in the previous slide, it just said that.
Is this one the slide that you were trying?
No, the previous one, ma'am.
Okay.
The wording is, will you give a parenteral midazolam which may hasten the death and not which would make the patient comfortable?
Okay, so I think I actually put this question deliberately. Did you get me?
Yeah, okay, ma'am. Yeah, it was just an initial response to the question before seeing the other slide.
Yes. So I've put that deliberately so that we understand the importance of inadvertent hastening of death and giving. Okay, if I would have put this as will you give parenteral midazolam which will calm the patient down, would you have given midazolam then?
Probably I would have.
Okay, all right. So maybe I'll take that point for correction. Next time, I'm going to put that as giving some kind of comfort to the patient. Okay.
Yes, ma'am.
Yes.
I would like to say, I think this the thing of hastening death. I mean, this line is, ma'am, actually, it is clear. I mean, from us, even as treating physicians, uh, uh, because even we have to realize so as to for what reason are we giving the midazolam.
Absolutely.
So for
Absolutely.
us also, it has to be clear so as to when we are administering a particular drug at a particular time. So why are we giving it, and why are we advocating to give that particular drug? In this case, midazolam. So for us
Absolutely.
also, ma'am,
Absolutely.
till the time we won't be, I mean, for us, for many of us here, palliative care is something which is a new thing, which is a new concept that is being introduced into our being, ma'am. So, and we will be facing such scenarios. So if we are
Absolutely.
not exposed to questions or terms like this, we'll not be able to, I mean, for I'm just talking for
Absolutely.
myself, we'll not be able to process it. For us, this question was a good one, ma'am.
Okay. No, no. See, even the previous question that Dr. Mehra had put, I deliberately used the question, the words hastening death, because that is what we are concerned about. All the time, we generally talk about, fighting death to the ultimate thing possible. And that is why we generally refrain ourselves from using midazolam or similar drugs in a terminally restless person, in a terminally restless patient. And that is where our dilemmas are actually complicated by many other issues, which are unwanted and unwarranted also. So maybe, even when we say, frame a question, will you give her parenteral midazolam, which will comfort her? That may also put us into this particular category of why are we at all trying to give midazolam? Why not avoid midazolam and do the conventional methods? Okay. All right. So, yes, let us come to this particular dilemma, this situation where this is a 74-year-old gentleman with advanced carcinoma of the lungs. He had completed a course of radiotherapy and 2 courses of chemotherapy. He's brought to the casualty. He's drowsy, his pulse is feeble, he has a systolic BP of 60 and an altered breathing pattern. The family wanted everything possible done to him. So, what do we do in such a situation? Number 1, resuscitate and shift him to the ICU. We need to investigate more. We need to give him a hemodynamic and a ventilatory support at this point. And we are also concerned about hydration and nutrition. Any responses? Yes?
To ICU, counsel the relatives about the prognosis.
Is this Sridevi?
Shift to ICU, counsel the relatives about the prognosis, hydration, nutrition, and then investigate.
Okay.
These were the responses in the chat.
Okay. Yeah. So, you see, the treatment that does not provide net benefit to the patient may ethically and legally be withdrawn. And the goal of medicine should shift to palliation of symptoms. That is what we call an appropriate treatment for this kind of a patient. Okay? Because now we do not know what will happen to him in the ICU. Will he be resuscitated? Will he get all the care that is important? Will he, get the relief of symptoms and the comfort that we are aiming at? What about those investigations that are being advised to him at this particular point? Are they going to yield us the amount of information that we need? And putting him into the ventilatory support, are these going to help him out? What about the hydration and nutrition? Are they justified at all? So we need to understand these questions, and maybe we'll have to find the appropriateness of our management when it comes to managing this kind of a patient, where perhaps we will have to, withdraw certain actions and shift our goal to palliating the symptoms. So here, the treatment key points that I would see myself is that what are the patient's biological prospects and the therapeutic aim and benefits of each such treatment that we advise. Thirdly, the adverse effects of each treatment. What might be those adverse effects? And the need not to prescribe a lingering death. Are we actually doing that by ventilating the patient? Are we actually prolonging his death? So this is where, the question of justice also comes in, because we need to balance the needs of the individual with that of the society. Maybe the imminent death in this particular person may not be justified when we put that person in an ICU bed, which will be of prime importance for a young person with a head injury in a RTA. So maybe balancing these particular things will have to be taken. So now coming to another question, another case where, this Mr. SS is 86-year-old. He was a journalist, working as a war correspondent. He was a thinker and a writer. He has cancer of the lung that has spread to the spine, rib, and sacrum. He has a son who's unfortunately, living with a psychiatric disorder. He has 6 grandchildren. Now, seeing his goals of care, what might be the goals of care for this particular 86-year-old gentleman? Maybe we can manage his pain. Some resources to look after his family finances, and some kind of his own wishes of the Janeru Sanskar for his 3 grandsons. At the same time, we also see that this particular patient is undergoing some kind of breathlessness, which is an important sign of he giving up on life. Now, will you advise an ICU admission for this particular patient? Is this a fair utilization of the family's resources? The family is already under financial constraints. What about the fair allocation of the hospital resources? As I talked about the other patient, the previous patient, this particular ICU bed may be of prime importance for a person, a young patient who has just had a head injury in a RTA, and of the society's or the nation's resources. So this is the principle of justice. This brings us to something called euthanasia. Any comments here? Any comments? Yes, somebody has raised. Yes, Dr. Abhishek. Yeah.
Yes, ma'am. Good evening, ma'am. This is Dr. Abhishek from Wayanad. Ma'am, in this case, we will have to respect the patient's autonomy on the kind of palliative care that he needs. If he is willing to spend the last few days with his family and at home, I don't think aggressive measures in treating his condition is necessary in this patient.
Absolutely. Absolutely. I completely agree with you. And where does the dilemma comes? Can you see any kind of ethical dilemma here?
Ma'am, the fact that euthanasia is still controversial, is that the dilemma here?
Sorry, I didn't get you.
Ma'am, the fact that euthanasia is still a controversial topic, is that the dilemma here?
Yes, of course.
Ma'am, also that his son is having a psychiatric illness.
Yes.
So, so just because though this guy is a terminally ill patient and he's ill and probably he is the only he is still taking on the responsibilities of the family. So from our side it may be like that he should be relieved of his symptoms and pain, but thinking on the social aspect, it may not be like, it will be like again, and like you say ma'am, it's a dilemma for us as for in general as well.
Absolutely. Absolutely right. I think,
There is
yes.
there is a comment in the chat
Yeah.
that if we can provide adequate reach of palliative care to everyone who need it, then we can think about euthanasia.
Okay. Let us come to the legal provision. See, there is a legal provision that is available. Okay, and it is IPC section 88, which it justifies the acts of not intended to cause death done by consent in good faith for the personal benefit. Unfortunately, we don't have much experience of translating this particular legal provision into clinical practice. That is where generally we slip into the practice of giving a good death to the person and holding us ourselves back on performing euthanasia. Can you understand what I'm trying to tell you? Let us see the other one. See, when we say futile care for a patient, which we just discussed, we are ethically not obligated to deliver care that in their best professional judgment will not have a reasonable chance of benefiting their patients. That is futile care according to physicians. We are not ethically obligated to deliver such a care. Hello? Yes?
No, I think there was some noise.
Yes. So, unfortunately, why do doctors go for futile treatment at this point of time?
Sanghamitra, there is one question from Dr. Nishant.
Yes.
I think, yeah, from the last scenario. What if the patient and his family are financially well and want hospital treatment in terminal stage? I think this is from the last scenario, I guess. What to do then? Should we refuse treatment?
Yes. So that is where we need to justify why are we at all giving this treatment. That is why I actually showed you this slide of giving futile care. Don't you think that, Dr. Nishan, that particular patient that we discussed about, we are going to give him a futile care even at the cost of their own expenses? Are we not doing that? So that brings us to, why do we want to go for a futile treatment? And the reasons being, physicians are oriented to curative treatment. Generally, when we are admitted in the first year of MBBS, the first thing that we learn is that we have to save our patients. We are not exposed to dying. We are not exposed to accepting death. And if we have to accept that, we feel that it is a failure of medical profession. So there is no training in palliative care at all. There is a fear of being blamed for suboptimal treatment. And there is an ignorance about the guidelines for end of life care. Now, this particular case that we discussed will definitely need some end of life care and not euthanasia. And if we talk about euthanasia, it is important that we understand the definition of euthanasia. It is always an active intention of killing the patient. So there is no question of doing a passive euthanasia. There is nothing called passive euthanasia. Euthanasia is always active. Now, for this particular patient, if we go for a futile treatment, that will again lead us to practicing the age-old things that we have been doing, and at the same time stop us from giving the actual end of life care that is required for these type of patients, which is not inside the ICU. So
Ma'am, I have a question.
Yes.
Ma'am, actually, what I'm always bothered with this question from several years of my this practice. See, ma'am, there's the suicide, homicide, and the death. You know, the way euthanasia is looked after. This is the Indian culture. Most of especially in the Hindus, killing one's life is a sin. So this thing is actually nobody, even if the people, I don't know that what stage nowadays some people will come out that I don't want suffering, but we believe in many lives. This question is several years, it is deep rooted in Indian society. So when we think about it, that first place, are we authorized to kill ourselves at any, it's not that suicide question I am asking, that for suffering. So why that so many years people are dying naturally? There is a deep rooted spiritual question here. So Western concept of this thing, it is somehow it is bothering us, because we really want a quick fix. We may not ask for treatment, but palliative care and the hospice is treatment is, I think, the choice, because this religious aspect and the spiritual aspect has to be answered. Patient must know, and patient has to agree, even with, is it spiritually acceptable to him. That's it.
No, that's true. That's I think that's one part of the story. Okay, see, we need to understand what is euthanasia first. Okay, see, it commonly actually refers to letting someone die naturally. All right.
Yeah.
So death may be avoidable in the short term and clinically postponed at the cost of lengthening the time the patient will suffer. Okay.
True.
So that is why passive euthanasia will refer to doing nothing to prevent the imminent death. Did you get my point?
Yes, ma'am. Yes.
So we are not doing anything to prevent the imminent death. And so, henceforth, we are actually allowing nature to take its own course.
Yes.
Isn't it?
Yeah, that is acceptable, of course.
Yes. So, when there is a question about actively performing euthanasia, it will amount to something called murder.
Yes.
Do you agree with me in this?
Yes.
Right. So when we know that it amounts to murder, then in this background, we will refrain from using the term itself, isn't it?
True.
Huh? And so
yes,
there is no existence of anything called active or passive euthanasia. Euthanasia is letting someone die naturally. That's it.
Okay.
Okay.
Now concept is clear. Thank
Oh,
you.
right. I hope I'm able to answer
Yeah.
the question.
Hmm.
The spiritual part that you rightly said is always there, will always be there. And when we are palliative care physicians and palliative care workers, spiritual care is just one part of it, and an important part of it. And when a
Yes.
patient is dying also, spiritual care perhaps becomes even more larger in its dimensions than the physical aspects. Okay?
Yes, ma'am. Yes.
And that spiritual care must be given to the family members also. We must not forget that.
Hmm.
Okay, if you want to know more about euthanasia, there is a very good document. You can actually there's an ICMR document which can go through, and there are Indian studies that have taken place. But unfortunately, the Supreme Court of India has given many some kind of a very confusing thing which has not answered the question that palliative care puts in. Okay, you can Sridevi may be able to share that document with you later on.
Yes,
Okay,
yes,
ma'am.
yeah. We
Thank
have
you.
a session specifically on end of life care where
Mhm.
usually Dr. Roop usually deals with that. So
Yes.
that's a very elaborate session, and you will get all the documents related to that. But even before that, if you want to read, you can just get that ICMR document on end of life care. All the glossary and terms, everything is mentioned very clearly in that.
This is a very bothering question, in fact.
Absolutely, absolutely.
Yeah.
I completely agree. And this has bothered all of us, and it will continue to bother.
And even in my practice also, I am a family physician, and with a very busy scenario, when this type of patient comes, that revealing the bad news to that handling the patient in the restless phase, things are very different. When you all are working as a palliative team, it is different, but treating in a casualty or among other patient, like CV has come, like some other thing, exacerbation of bronchial asthma come, in that scenario, when such type of patient do come to us, it is very difficult. We hardly get time, and we need special skill. In fact, it need to be taught in a different way so that we can handle. So it is very enlightening for me, of course. So I hope, intend to learn more from you all.
Yeah, I think this is only the fifth session, so there are many other sessions where you'll always be, surrounded by many learning processes, and this will be very interesting in the long run. And you'll learn more. In fact, we are always in a learning phase. Today, also, when I am actually talking to you, I'm learning new things. Okay. So this slide I wanted to show you because you can go to the IJPC website. IJPC is Indian Journal of Palliative Care. There is an end of life care policy, and it is an integrated care plan, very properly designed for dying patients. You can actually see there are a lot of lot of guidelines that have been put in together. It's going to guide you even better when you deal with such patients later on. Okay. So
Sorry, there are two comments in the questions rather in the chat. What if the family members insist all possible care, even if we tell them it's futile? Sometimes they become more aggressive, and there is instance of violence against doctors.
I think the
That
best
again, previous scenario might be, but yeah, if
yes,
you
the
would
best way is to sit with the family, tell them what is the future prospect or future aspects that you need to that they need to find out, why the futility of treatment is so called as futile treatment. What would happen to the patient if you make the patient undergo such futile treatments? What are the side effects? You'll need to press upon the adverse effect, because every family, will, as we discussed, are protective about their patients. They want to give the best care to their patient, and you will need to perhaps talk about more of care rather than doing interventions all the time, which are not going to yield anything to the patient, and at the same time make the patient suffer more. Tell them what happens when you put restraints on an ICU bed. Tell how the patient realizes that he is unable to express himself at that point of time. I always generally tell the family members that till the last moment the patient's hearing is intact, unless and until he has had some some kind of defect in the ear, some pathology in the ear. The patient is able to hear everything that they talk. So I ask them to talk good about them. I think the communication skills that we generally develop over the years by practicing palliative care, by dealing with death and dying, by giving an importance to prognostication of our patients. These are the tools that you can use to actually give that benefit which we intend to do to the patient and the families also. I understand that this may not be possible with every family, and you generally nursing homes and doctors are being beaten up, the hospitals are vandalized. I think the most important thing that we do not do as physicians, as normal physicians also, is not to communicate things at the right moment to this patient. Communicating everything is very important. You will need to sit with the patient's family. You'll need to, build up that particular rapport, and you will need to tell them, reinforce the fact that you are a friend and not a foe. So I think this comes by practice. And, at previously also you'll have, as I myself have undergone these things when I transitioned from a family physician to a palliative care physician, is that I had some kind of ego. Yes, I am a doctor. They should come to me. They should talk to me. No, it's not like that. We intend to give something, and for that, we do not need to hammer information to anybody. We just need to communicate them properly, confidently, and develop that relationship that will help us and the patient. After all, both the family and the caregivers and the doctors and the staff are all aiming, or the common goal is to give relief to the patient. I think these things will need to be considered. Sridevi, will you need to add something to this that I've said?
No, I think it's very clear. You've covered it.
Yeah. Okay. So yes, so we've already discussed about the euthanasia. So there's something called DNR. Do not resuscitate. And any inputs on DNR? So, these are advanced directives, and we use them so that we are legally safe, where we will surely be confronted in the court of law. If at all, the family decides to drag us to the court, which generally doesn't happen normally. As I have reiterated, I will actually reiterate again that our communication skills, they are the major ammunition, and they can help us make a decision on the use of drugs like morphine or midazolam, and the approach of, declaring a patient to be at the end of life, as you will see in the end of life care guidelines that IPC has put out, that it's a consensus between the medical team and the patient, if the patient is capable at all, and the family. So it's essentially it's a long process. So I think we've already discussed about euthanasia at length, and so yes, something that I would really advise all of you to read, Being Mortal by Dr. Atul Gawande. Our medical system, generally, he said that it's excellent at trying to starve off deaths with chemotherapy, with intensive care and surgery. But ultimately, the death will come, and no one is good at knowing when to stop. So I sincerely request all of you to please read what Dr. Gawande has gone through himself while dealing with death, So we cannot afford to die in the ICU. As you can see these facts, 85% of healthcare spending in India is out of pocket. 39 million Indians, they become poor every year due to rising healthcare costs. And most are related to aggressive medical interventions at the end of life care, at the end of life. And there is a 300% increase in inpatient expenditure in the last 10 years. So these are facts that we cannot ignore. Okay. So our take-home message should be, we should apply ethical principles against a background of, number one, respect for life, and secondly, acceptance of the ultimate inevitability of death. I think these two things, if you consider every day while dealing with such patients, all your dilemmas will be cleared off, and you will be in a better position to deal with dilemmas and follow the ethical guidelines. Okay, so this is how, perhaps the picture that you can see on the left side, this is how I would want to die, and not like the other one. Okay, so thank you so much. I hand it over to the group for more discussions.
Thank you, Sanghamitra. That was very extensive discussion and thought-provoking. The questions were also really good, and the discussions were actually quite a lot of points to learn. Yes, we will be dealing in detail about the withdrawing, withholding care in end-of-life care, but in the medical ethics part of it, we have covered really well. I was thinking, why can't we start the presentation, and then because there is also dilemmas involved, questions involved in the presentations, and we can come back to this discussion part after the presentation.
Yes.
Sri Priya?
Yes, ma'am, sharing the screen.
So is Dr. Vinita available in the session?
She had logged in. Dr. Vinita, do you have like? I believe she's having some connectivity. Maybe she's in emergency department.
I saw her in between. So she told she is in emergency duty. So we'll read out the case and she'll jump for the discussion. Next slide. So this is a 63-year-old male with carcinoma lung with metastatic I think carcinoma lung with metastasis, vascular dementia, SAADH, seronegative arthritis, severe neutropenic sepsis, and small bowel perforation and peritonitis. The presenting complaints are lower abdominal pain since 5 days, history of constipation for 4 days, and not taking food since 3 days. He is a known case of small cell carcinoma of lung for which he had taken radiation therapy and now on chemotherapy. The last chemotherapy was given 3 days before admission. He had multiple brain metastasis, vascular dementia, seronegative arthritis, seizure disorder. So he came to emergency department with lower abdominal pain, which was mild twisting type of pain present throughout the day. History of constipation present, and the patient had bloating sensation and was not able to take anything orally, following which he had vomiting. So patient was conscious oriented, responding to oral command. Vital seems to be okay. 88 beats per minute, BP 110/70, 20 cycles per minute of respiration, SpO2 92% at room air. S1, S2 heard no added sounds, and there was decreased air entry on the right upper zone. A heart tenderness present all over and guarding present on per abdominal examination. The patient was initially treated with in emergency department with IV fluids. A right tube was put and continuous aspiration was done. Patient was shifted to SICU for further treatment. All routine investigations was done, which was in normal limits except for anemia. ABG was done, which was normal. CT abdomen, pneumoperitoneum with prominent large bowel loops with maximum diameter of 5 centimeter. Cecum and ascending colon appears to be fecal loaded. And CT thorax, there is a right hilar mass associated with compression of right lower lobe bronchus and its segmental branches noted with resulting collapse and suspected mediastinal extension in the subcarinal region. So he was planned for exploratory laparotomy. He is a farmer by occupation. He had 2 sons and 1 daughter. Just a moment. Sorry. So he was a farmer by occupation. He has 2 sons and one daughter. First son was a driver and second son was farmer with whom he was staying. Wife was a housewife. He was always cheerful and wanted to be happy in front of everyone. He had underwent radiotherapy and chemotherapy for which he had to travel a distance from his home place, which added to his expenditure. He was treated with higher antibiotics, antiemetic, nebulization was given 8-hourly with bronchodilators and steroids. Trials tube aspiration was continuous. Anti-epileptics IV started, planned for exploratory laparotomy. So the main concerns were advanced cancer, whether to go for surgical banishment and post-operative survival rate. So in summary, a 62-year-old male with advanced carcinoma of lung with metastasis to brain, vascular dementia, SIADH, arthritis, neutropenic sepsis, and bowel perforation with peritonitis. So, so this were the discussion points sent by Dr. Vinita. How to proceed with further treatment and what about the financial burden of the patient. So I think she's asking more about whether to advocate for more surgical options. And she's already mentioned in one slide that he has to spend a lot of money just to get the treatment available. So what about that? Should we recommend more treatment or how should we deal with this patient? Thank you, Dr. Vinita. I don't know whether she joined back. So I think we'll take this up and start the discussion. How would you want to go about in this case? Would you want to recommend a surgical option? And what about the outcomes? Whether he's going to get a reasonable quality of life? What will be the quality of life after the treatment? And what will be the prognosis? Thank you, Dr. Vinita. Yeah, I think Sanghamitra has some emergency and she has to leave.
Yes, ma'am. She had informed due to some medical emergency at her family, she have to leave the call.
So, what do you think? What the others think about the surgical options, and not just surgical option for any treatment? I understand he has to travel a long distance and go there. So, what do you think? I get understand there might be oncologists in the group or even general physicians. So, what do you think should be done for this patient? So, Dr. Shavaria is telling he's already in a respiratory compromise. On-table mortality already would be very high, and not just living with the quality of life in post-operative stage. So we should counsel the patients and attendants about the poor prognosis at home care with adequate pain relief. So, Dr. Nishant, would you like to say what medical, like what should be, I understand the medical management part. So what should be the goals of care and what should we tell them that we are going to provide? Uh, you would want to respond to that? Dr. Krishna Priya is telling surgery will not be a good choice for him. Relieving the fecal matter obstruction will help. Is there any option to relieve the fecal matter obstruction? No, I'm just asking generally to the group because we in palliative care we very often come across this fecal impaction.
One way would be, since we know there is a hollow viscous perforation, so medication in any case is not going to allow, I mean, is not to, I mean, medical management is definitely not going to help. Secondly, we all here know that surgical, it looks like that the surgical procedure intervention, the patient will not be able to withstand. One thing we can do is that we can do digital evacuation. That can be of little help.
Sridevi ma'am, do we have you on call? Sorry to interrupt, ma'am, but your voice is.
Would you like to talk something about the IV fluids? Do that. Sorry, I think I have some internet issues.
Ma'am, I don't have much experience about it, but if there is any perforation and all, and we have to somehow rest the bowel, so giving some fluid and nothing per orally and digital evacuation, all those things can give some amount of palliation relief to his condition.
Sorry, I lost. I'm getting uh, leave from the meeting because of the internet issues. Sorry, I couldn't hear Dr.
Ma'am, your voice is also not clear to me, but still I feel that IV fluid and nothing orally for some time, maybe 48 hours like that, and digital evacuation of blood bowel will give some relief to the patient.
Yes, I understand. So I was slightly touching upon the NPO part and maybe the ethical part of it. So when we know that the prognosis is really bad for this patient, and we see these kind of patients almost every day probably, where they have some advanced illness, and we know that the patient might be dying, maybe few hours to days left in front of them. So do we really want to keep them NPO? Or what do you think? There is no right or wrong answer. So that's a very clear ethical dilemma. Should we feed them or should we tell them to be on NPO? What do others think about? Anyone would want to comment on that? That's a very common instruction that
Yeah.
patients get when they have a bowel obstruction. Shripriya, am I audible?
Yes, ma'am,
Yes,
you are
ma'am.
audible.
Even it will stop vomiting
Yeah.
part also, because that vomiting will start if we keep on keeping food by mouth. So
Yes, I agree. So I was just remembering about a few patients that we had. They knew that they were dying. They had severe, unrelieved, complete obstruction. And when they were referred to us, they were on TPN and NPO. But they were still vomiting. They were still vomiting. And they knew that they were dying. So at least some of them expressed the wish to eat something by mouth. We want to taste it. So we gave the option of NG tube, if you're hungry, or peg, depending on the level of obstruction. But many times they want to taste the food. I want to have something with the family. And another point was the family could not take food because they feel the loved one is not feeds properly. So how can I eat food? Or how can we cook even? Because that smell comes, and then you tell them that the patient is an NPO. So that causes a lot of distress in the family. This is something which I personally have just sharing personal experience. So many times that becomes a distress among the caregivers as well as the patient. So that's one thing that we need to consider, because the prognosis is really bad. Is it possible to reduce the vomiting? Is it possible for the patient to taste a little bit of food, especially when during their last few days of life, to have a spoonful something along with the family? So that is something that we need to consider during the situation. We will definitely come into the details of it during the session and bowel obstruction, but it's something, an ethical dilemma that we might face as doctors.
I have a very silly suggestion. I don't know, because the taste is only in mouth and tongue, ma'am. Once the food bolus crosses the tongue level, there is no taste sensation. So we can allow the, if the person wants, we can tell them there's a chewing the food, that he can experience the taste. Later on, he can throw that redundant part. I don't know, but I think the taste part is that patient can taste food.
Yeah. And that's not a silly suggestion, Dr. Krishna Priya, because we had patients who used to
Hmm.
do that, because
Okay.
they just wanted to taste that, but they know that if they
Yeah.
take it in, they are going to end up in distress. So they just want to taste it, and
Yes.
then they spit it off. And there were some of them actually who used to take food, but then they were having a draining tube, either NG tube. Two of them were on in a Riles tube for aspirating the contents. So the moment they take food, they experience the nauseating sensation and the distension. Then they drain it out. So they were quite happy with that. They had the tube in place. The moment they take food, they feel that distension feeling, and then they drain whatever stomach contents were there. Those were
Hmm.
during the last few hours or days of their dying, but they were so happy about it because they were unable to taste or smell anything for the last few days when they were with some other hospital. So these are the ways patients adopt in terms of dealing with such situations. So yeah, so we are not going
Yes,
into
ma'am.
detail about this bowel obstruction management, but the ethical dilemma
Ma'am,
involved
ma'am,
in feeding. Yes, Dr. Vinita.
ma'am, actually, in my patient, the bowel perforation was due to metastatic. It was spread to small intestine. So that is gay, and he had the perforation. So he had pelvic connectivity. So they were not able to put a drain. So they it was to at least that peritonitis.
Dr. Vinita, is it the problem with my network, or was she clear to everyone else? I couldn't hear anything. The network was.
Yeah, network was problematic. We also
Oh,
couldn't hear.
Hello, ma'am. Hello. Hello.
Yes, yes, Dr. Vinita, can you try again?
Ma'am, actually, in that case, that perforation was mainly due to that metastatic lesion which gave away. So that small perforation was due to the metastatic lesion. So the patient had pelvic collections for it has to be drained. So they were not able to do put a drain under local also. So they wanted to do surgery only because it was a pelvic collection.
Okay, got it. So there were no other options other than surgery being considered for this particular patient, right? So I think it's Dr. Shaurya who's mentioned about if not surgery, then it's I think it's someone else. If it's not surgery, then the other option will be giving end of. I think Dr. Shivakumar. If not surgery, the only option will be end of life care. I think I totally agree to Dr. Shivakumar's comment. If they are unable to do surgery, so should we actually talk to patient or advocate for surgery is one question that I have. Because as if your patient will come and ask you, doctor, what should I do? This is the option that they have given. Should I go for surgery? Is it going to save my father, or is it going to save me? So that's the usual question that you're going to face. Tell me what to do. We don't understand anything. You are the expert. So tell me what to do. If you think that surgery would work, we can somehow manage it. So in this situation, how would you deal with that? Would you want to recommend surgery or end of life care? And these ethical dilemmas, there is no right or wrong answers. That is why it's called dilemmas, because there is always a dilemma behind it. There is always a confusion, and we always have to have a team with whom that this case can be discussed and ask what do they think. If you think that you are totally confused and you think that you cannot make the right decision,
Ma'am, if we are deciding for end of life care for this particular patient, then we have to realize since he has already has a hollow viscous perforation, it will be a very painful. The patient will be in like a lot of pain, physical pain, both due to metastasis as well as the and as well as due to the peritonitic pain due to perforation. So pain relief, trying to maintain hydration will be the most important thing, I guess.
yeah, sorry, I lost in between. I don't know what happened to my network today. I heard the last part of Dr. Arpita said about pain relief and controlling the symptoms and keeping comfortable.
Yes, ma'am.
Any other thoughts about advocating for, if the patient asks that question to you, what should I do? Or the sons come and ask you, should we actually take him to hospital? Is there any other opinion other than what Dr. Arpita was mentioning? And I think to add on to that, it's very important to explain the prognosis or what is to anticipate to the family members as well as the patient. If surgery is not an option, then it is very important to prepare the family. As you have all mentioned, this is a very complicated scenario where patient may not live longer and with a lot of complications. So it's very important to make the family understand what is next, what are the symptoms that we anticipate. It may or may not happen. It's very important to prepare the family and to offer what or list out what can be done. Suppose if the pain happens, this can be done. If the vomiting increases, what is the option? So all these things have to be discussed with the family. Whatever decision that we are taking, it's very important to prepare the family to go through that phase after the decision. That's also very important. Even if it is a surgical option, it is very important to prepare the family. What is the next? What are the complications that we anticipate, and how to deal with them? Whom to call? What to do? So those
Ma'am,
discussions are also here.
I would
Yes.
think that sending away the patient home and give a palliation care at home will not be a very good option, because right now, in spite of the fact that he's having is in a metastatic advanced cancer stage, but then now the main there's a big topic of a surgical emergency, and now we are from henceforth we are deciding to go for a palliative care. Sending them home will not be like a good option. We could provide palliative care right in the hospital, with taking into account their primary caregivers, and then to because seeing him, I mean the patient in in a state where, because of the hollow viscous, his symptoms will be exaggerated to a very big extent, which can be managed only in a hospital setting. So palliative care given to in the hospital setting, I would think in these terms.
Yes, yes, Dr. Arpita, thank you for that. Yeah. So many symptoms, there are some refractory or difficult symptoms which might need a brief admission to the hospital or a hospice setting, and then send them back home if at all possible, if that is a possibility. Many times that may not be a possibility also. Thank you, Dr. Arpita. Are there any other comments, even about the medical ethics session? Or about the case presentation? Is there any other point that you would want to discuss? Any questions that I left unanswered in the chat? Please let me know, or you can send it in the WhatsApp. Shripriya, is there any question in the chat? Which we have recently, because I logged out in between, so I lost the track.
Yes, ma'am. What I can do is I can just take
Yeah,
the
I can just see that. No, I can just see the chat now. Dr. Shivkumar, yes, IPC section 88. I understand Sanghamitra touched upon that, but we have a very detailed discussion about all these topics in end of life care, which will be taken by people who are actually involved in coming up with the joint position statement. So you will get a more clarity about that. That's why I don't want to touch upon that because that session is very in detail session on end of life care, and all these legal implications, advanced care planning, how to document, everything will be dealt in that session. I can't see any.
Ma'am? Hello? Hello?
Yes, Dr. Vinita, you're audible. Please continue.
Actually, when we explained the risk to the bystanders, actually they were ready to they accepted for the surgery to proceed because there was no other option for this. So we went for the surgical procedure only for him. Patient was fine. Like for the first 2 days, he was fine. Post-operative day 2 also he was fine, and gradually he developed neutropenic sepsis, and actually he succumbed to death because of sepsis on 6th day.
Thank you, Dr. Vinita, for that update. So that makes me think about an interesting question. What were the options given to the patient? Is it just surgery is the only option, or were there other options that were given? If not surgery, we can take care of your symptoms, we can control your pain, we can control your vomiting, everything, or was surgery the only option given?
Actually, ma'am, patient had, and it gradually increased. So his abdomen was becoming more distended and distended because of peritonitis. So the surgery was only the option.
Yes, I got it. So I think that's one take-home point that might be considered after today's session. So, as Dr. Rajgopal was mentioning in the first session, that there is nothing more can be done. If the surgical option is not there, as mentioned by many people in the chat, there is always a place where we can control the symptoms and to make the patient as comfortable as possible. That may not be the ideal option, but that is an option that we should discuss with patients. Especially all these dilemmas are there because the dilemma might not have been a problem there because there was only one option there. Now, at least from now onwards, we might be able to discuss that. If not surgery, what is next? That's the usual question asked by the caregivers, right? Doctor, what if I am not, we can't do the surgery? What is the next option? Then the answer is naturally, then we can't do anything about it because this can be done, corrected only by surgery. So I hope everyone here has kind of agreed through the chat that we can always keep the patient comfortable, if not the disease modifying therapy. Still, the goal can be changed, but there is something always that we can offer them to do. Note, I think we can end today's session. Thank you, Dr. Vinita, for that wonderful in detail scenario, and thank you for updating actually about it. I totally forgot I wanted to ask that in the end, what happened to that patient, but I somehow missed it, and thank you for pitching in there. And Sanghamitra, we are really sorry.
Yeah, ma'am. Actually, the patient had that lung metastasis. Actually, when we took the CT, like before shifting to the OT, actually he had both obstruction of both the upper bronchus and the middle bronchus. So his both upper lobe and middle lobe was collapsed. So there was no air entry at all on the right side. So we went for regional only, like combined spinal epidural, without giving GA, without affecting his respiratory part. The intraoperative period, he was very fine. Postoperative was also fine. Later, he went into neutropenia and then sepsis.
Yes, I think Dr. Vinita, I think essentially the surgery is not the cause of death. That's what you wanted to convey, right? Yeah, I understood it. So thank you so much for clarifying that. And we are really sorry that Sanghamitra had to leave a bit early due to the COVID situation at her home. And thank you everyone for joining us for today's session. We'll be back with another topic on Friday. Shri Priya.
Thank you, Dr. Sridevi. I believe this was a mutual learning session for everyone out here. So with that note, this is Sri Priya along with Dr. Sridevi Warrior signing off from the TIPS Echo Desk. See you in the next session with an eminent faculty and interesting case presentations. Till then, everyone, take care, stay safe, stay healthy. Bye-bye.